Welcome to the ICU Management and Practice DigiConf Antibiotic Resistance. Our Editor-in-Chief, Professor Jean-Louis Vincent, will moderate the session. Our panellists include Jan de Waele, full Professor in Internal Medicine, Jordi Rello, full Professor and Senior Consultant, Haifa Algethamy, Associate Professor, Faculty of Medicine, and Ryan Maves, Professor of Infectious Diseases. Let us now welcome the moderator for today's DigiConf, Professor Jean-Louis Vincent.
Hello, hello. Nice to meet you all at this discussion on antibiotic resistance. Obviously, a very important topic covered by ICU management and practice today. And clearly the topic has raised much interest. We have a number of people with us, and we will keep track of them in just a moment. But I don't want to take any delay. We have only 1 hour and 4 excellent speakers here, and they were already introduced a minute ago. So I will immediately allow the first speaker to address the topic of pharmacokinetics and pharmacodynamics in 10, 12, 13 minutes. We hope after the 4 talks, we'll have some time for discussion. So Jan de Waele from Ghent, you are welcome to start, my good friend.
Thank you very much, Jean-Louis, for the kind introduction. And yes, indeed, in the next about 10 minutes, I would like to zoom in on the potential role of the PK/PD optimized approach to combat antimicrobial resistance. Now, essentially, there's 2 main topics I would like to discuss today, and this is, on the one hand, treating antimicrobial resistant infections using the PK/PD optimized approach, as well as preventing them. These are my disclosures, none of them, in fact, relevant for this particular presentation. This short overview is actually a summary of what, together with Sophie Daas and Irina Boelens from our hospital, we wrote on this in the one of the latest edition of the journal. So for more information, please dig in. I'll give you the link in a minute. Now, it goes without saying, of course, that antimicrobial resistance is an important problem, not only in the ICU, much broader, but specifically in the ICU, of course. It is estimated, these data come from Europe, and it is estimated that about 33,000 patients a year die of antimicrobial resistant infections. And as you can see here at the bottom, it is clear that a lot of these infections actually develop in the ICU. 75% of these infections are estimated to be healthcare associated infections. And over time, the burden of these infections has significantly increased. You can see the data there, 5 times, 4 times increase in different pathogens when it comes to mortality. So an important problem, not only in Europe, but of course also globally. So this is why it is worth trying all ways to kind of prevent and treat these pathogens. And in the past years, there's been an increased interest in using the PK/PD approach when it comes to antimicrobials. So it's about integrating pharmacokinetics, how the drug behaves in the body, and the pharmacodynamics, how this drug has its activity, namely killing of the pathogen, how to both integrate these and optimize the strategies in terms of dosing administration. And this is a figure that you probably have seen before, distinguishing between drugs that are concentration dependent, where you want a high concentration for the effect, and others like the beta-lactams that are time dependent, where you need a prolonged exposure. Now, so far, we've mainly been focusing on the treatments when we discuss this, but I'll show you in a minute that also for prevention of antimicrobial resistance, this has absolutely value. Now, we have identified different PK/PD indices. I've shown you them in the figure before, but the AUC over the MIC, the time above the MIC, the maximal concentration over the MIC, depending on the drug that you are using. So typically, again, we use them for efficacy, we use them for treatment, but also to avoid resistance. Yes, these can be used. Mainly, this has been studied in animal models and in vitro models. And I'll show you now some data from an in vitro model using a hollow fiber model where you can actually mimic an infection, not for 24 hours, but for longer days, and look at how the pathogens behave when different concentrations of antimicrobials are there. And this specific situation, this is in a model where Pseudomonas aeruginosa was used, and looking at different doses that were administered in this model, you can see, and let me bring on the laser pointer, you can see on the left-hand side that over the 5 days, 120 hours, in green, you see the pathogens, the susceptible pathogens that actually, the total pathogens that increase, but the red dots are the occurrence of resistance pathogens. And you can see that with low doses, after a few days, these resistant pathogens, they develop and they take over much of the infection. Whereas in higher doses, like 17 grams, what you can see here, you see a bit of resistance developing, but it never gets as big as with the lower dosing. So using different dosing, and the same has been done for dosing strategies, you can actually try to prevent antimicrobial resistance developing. So it seems to be this dose-dependent suppression of resistance. So this is why, depending on what strategy you want to do, what goal you want to reach, whether you want to adjust for short-term reduction of the number of pathogens, yes, indeed, these more conservative low targets, such as 40 to 70% of the time above the MIC, are enough. Whereas for a prolonged suppression of resistance development, you need higher targets. So that's a very important thing to consider for suppression of resistance. It is possible using a PK/PD optimized approach, but higher targets are necessary. And this figure exactly shows you this in a different way. Below a certain concentration, there is no selection pressure. And this is typically the MIC. That's what we aim for. And above this window, there is this zone called the mutant selection window, in which there is suppression of the majority of the pathogens, but you allow resistance developing. It's only when you get your drug to the mutant prevention concentration that both susceptible and these mutant strains are effectively inhibited. So this is why, yep, maybe we should be focusing on the mutant prevention concentration more than on the MIC. Well, we do if we want to prevent antimicrobial resistance from developing. Is prolonged infusion the strategy we often use now in clinical practice to optimize antimicrobial exposure for treatment? Is this also possible for suppressing antimicrobial resistance? The answer is yes, probably. But again, you will have to aim higher and try to get 100% of the time above the MPC, not the MIC, to get suppression of resistance. Of course, if you are stuck in this window, and this is an inherent risk, then you may actually allow mutants to be selected. So much for preventing antimicrobial resistance. The concepts that we've learned in the past years to optimize treatment can actually also applied to optimize to prevent the development of resistance. And I'm sure we'll learn more of this in the future. So on the other hand, PK/PD can also be used to treat antimicrobial resistant infections, so less susceptible, borderline resistant infections. This is specifically based, of course, on the MIC. This becomes a very important value in this. On average, we will have to aim higher and probably optimize administration as well. And combined with therapeutic drug monitoring, this could be the clue to also treat these resistant infections with antibiotics that we use a lot. Synergism is another aspect, another dimension of PK/PD optimized therapy, where you actually use two drugs, not one. And together, these drugs have a higher effect than when you would give them separately. This is just one example, in fact, from the Erasmus Hospital in Brussels, published already a few years ago, but still showing you nicely the potential of this. This was a patient who was treated for an infection with an extensive drug-resistant Pseudomonas aeruginosa. And over time, this covers 3 weeks, as you can see. Over time, this patient initially had developed a septic shock, but as the MIC that you can see here at the bottom line increased from 2 to 8 in the Pseudomonas, different strategies going from 1 gram over 2 gram every 8 hours up to 3 gram every 6 hours, and extended infusion was used to optimize the therapy. So in the end, 12 grams in optimized perfusion was used. Of course, now you may have other drugs at your other drugs that are available, but this clearly shows you that there is a potential for this approach. And also in the latest guidelines, this comes from the one of the latest CMI articles, the guidelines on the treatment of multi-drug resistant gram-negatives. Also there, these optimized dosing, optimized administration by pathogen and indication, of course, combined with TDM, was considered to be a good clinical practice. So definitely something to consider. What does the future look like? Well, I think we need more research into what concentrations we need to avoid selection of resistance, not only looking at in vitro models, but of course also real world situations with real world inocula and a not 24, but 4 to 7 days treatment. Now, overall, of course, higher concentrations, higher doses will be necessary. And in a recent article, we elaborated on the concept of a maximum tolerable dose, dosing higher up to the level that the patient develops. The big problem, the big uncertainty here is that we're not sure about what concentrations are effectively toxic for our patients. So again, if you want to read more about this, this is a QR code that will get you directly to this article. And in conclusion, Mr. Chairman, these PKPD principles that we learned a lot about in order to optimize the treatment of infections does also have value in avoiding resistance development. So definitely something that we need to study much more. We don't know, however, what concentrations of a drug in the plasma, in the tissue, we need to avoid this resistance development. Could also here, as in treatment of pathogens, prolonged infusion be a solution? I think it could be part of the solution, but again, not the only thing. Combined with higher dosing, optimized use of therapeutic drug monitoring, and potentially also combination therapy, this is what the future could look like. Now, in any situation, the basics, the principles of antimicrobial stewardship, they also apply when we try to prevent antimicrobial resistance as much as when we want to treat antimicrobial pathogens. And with this, I would like to end and, of course, look forward to discussing this.
Thank you very, very much, Jan de Waele. That was very clear and very interesting. We could have many questions, but I see that we have used our 15 minutes. So we will keep our questions for later. I'd like to indicate that we are now more than 220 participants here. So there is a good crowd this afternoon. And we have one question, but I will keep it for later. Because the next topic will be indeed the one of stewardship. So there may be a little bit of overlap. And so, Jordi, Rello, please, you are another expert in the field, of course. And the floor is yours, if I can say so. We are all watching your presentation, my friend. Go ahead. We cannot hear you. Jordi? Yeah.
Yes.
Let's go.
Good afternoon. Good afternoon.
Yeah, good afternoon. Go.
This is a summary of the article that was reported recently in ICU Management. And I think that for introduction, it's good to look at the prevision of death by antimicrobial resistance for 30 years. So this is showing mainly what are the most important threats in the world. They are an important problem with road traffic accidents, cancer, diabetes, diarrheal diseases, and even some conventional diseases in low and middle income countries. And this is the current antimicrobial resistance, and it is expected how it will be going for the next years. Cancer will increase with an 2 million of deaths by 2050, and it is expected 10 million of death by antimicrobial problem. In 50. So many years ago, in the same month, practically, it was reported two different perspectives of antibiotic de-escalation in sister journals, the current opinion on critical care and current opinion on pulmonary medicine. These two articles, because they show a very different perspective. One is the American perspective, the other is the European perspective. So it is clear that we need to have a new way of prescribing antibiotics in sick patients, because the old way does not work. It is that using fewer antibiotics is better than more. The restriction of appropriate antibiotic therapy is clearly bad between resistance and efficacy. And here is where infectious diseases and microbiologists put a lot of importance on resistance, and it's true. But from a perspective of a clinician working in the emergency department or in critical care, outcomes are extremely important, should be the priority. So efficacy is important. And we need to
Jordi,
have a good balance distance.
Jordi, you are still showing the same slide? You don't have other slides to show?
No. I'm moving the slide.
We are still looking at the first slide, but perhaps you have no other slides and you will make a comment without illustration. But you may not have shared your screen properly if you wish to show.
That's the 86 slide. Slide number 6.
No. Then you need to share a screen. You are not sharing your screen. If you like, we can play the slides for you. Do
you see now what are the goals of antibiotic stewardship?
No, it doesn't move. It doesn't change.
No?
You should share screen.
Sorry.
You should share screen and go on your computer and find the appropriate slides.
Yes. I don't know why we have this problem. Sorry. Now?
No, nothing.
No?
Now, yeah. Now, yeah.
Okay,
so,
now?
So now is the balance. Objective.
This is the balance.
Yeah.
Okay.
The goals of antibiotic stewardship. Yeah. Okay.
These are the goals of, shall we? So it is a combination of optimizing clinical outcomes plus comprehensive infection control measures to reduce emergence and transmission of resistance. This is achieved by different combined focus on toxicity, on selection of pathogenic organisms, in the emergence of resistance, and also an important issue, pressure. In the patients of focus in the hospital. For the patient is obviously mortality readmission. But for the hospitals, because this is not dopamine or propofol, it's important that it's efficient. Of stay is an important outcome, emergence of resistance, safety, collateral damage, and finally, the small part of the outcome, because typically in the ICU, what is more expensive is 1 day extra of language come for the stewardship. Some are strategic and require team working, require very good improvement in providing information and communication to all members of this team. Another issue is operational barriers. And incorporate the escalation as a tool. And finally, educate effectivity lead. For antibiotic optimization, it is important to develop an antibiotic care bundle with right drug, right time, right back. And this is also covered by the different panelists of patient that is extremely important for the emergence of resistance. And this has to be combined, of course, with infection control. What is the right dose? Well, it has been previously mentioned by Jean Deval. It is important to know your local organism and their susceptibility according to the main principles of PKPD. And another where nephrotoxicity, emergence of resistance, and pharmacologic interaction are the three most important issues. This is a very old slide from the past century, and in which a landmark study of Paris by Jean Chastre reported the distribution of pneumonia in patients longer than 7 days of ventilation with prior antibiotic. And when we look at different centers, this is one neurosurgical ICU in Seville, the problem was different. Pseudomonas was present, but it was a different distribution of the other pathogens. And here, it was an important problem with MRSA. In Uruguay, in another neurotrauma ICU from Professor Humberto Correa, it was a different distribution of agents with more non-fermenters, being Acinetobacter an important problem. When I was doing this, I was working in Sabadell in Barcelona with an excellent team. And here we have main problem with Pseudomonas. And I was moving 1 year later as head of the ICU department to Tarragona. And with the same kind of patient, we have a different distribution. Know your local pathogens to accommodate your decisions. This is one of the best analysis of the escalation in clinical practice. When it was formulated, but they are only a minority of patients, approximately 1/3, in which the escalation is feasible. In others, medication has to be changed by poor clinical resolution of adverse events, and in others, it is no organism, so it's not possible to de-escalate. This is emphasizing the importance of microbiological tests in clinical practice. Most physicians have fair and they say if the patient had a mortality rate under 20%, and in the same core, those patients that mortality. Important because in the 90s, clinical practice guideline recommended up to 3 weeks of therapy for And this is patients with pneumonia. Ended 2 weeks. And this was a landmark study from this MP3 group, in which it was documented that 1 week exactly the same in terms of I'm doing clinical practice right first time, covering all likely organisms, diagnostic test, facilitate to do this laboratory and de-escalate according to the report of these cultures. And it is crucial to look at the patient. You have to identify the clearance and particularly improving in oxygenation. And depending on this, you have to take your final decisions. So my take-home message is how I would do it. And this is adapted for pulmonary and critical care physicians. Practitioners are causes and solutions. Microbial stewardship should be considered a core competence emphasis in this issue. Rapid diagnostic tests, unfortunately, antimicrobial stewardship should address fear of delay empirical choices. And it is needed that the attending is confident with the practice. Adverse events of excessive antibiotic affect individual patients, but the primary focus should be improving antibiotic use rather than reducing cost or increased escalation. And rapid diagnostic tests, broad coverage, hit hard for success. Thank you very much.
Thank you very much, Jordi. These were excellent thoughts and advices that are certainly very appreciated. Sorry for the technical problem at the beginning. And also, I must say, your voice was often frozen during your presentation. So it was sometimes a bit difficult to follow. But nevertheless, we perhaps, if you can do something about it, do it. If you think you need to leave and come back, because we'll move to the third presentation now, which we'll keep our questions for the end. We have several questions already in the system here, but let's move to Professor Haifa Algethamy from Jeddah, from the Professor Abdulaziz University, and she will discuss how to decrease antibiotic resistance in the ICU. So Haifa, the floor is yours.
Good evening, everybody. Thank you very much, Prof. Vincent, for the invitation. It's a great pleasure for me to be with you and ward expert this night. So I'll talk about strategies used to reduce antibiotic resistance in the ICU. Slide ما تتحرك يا.
Still the same slide, yeah?
Yeah.
Can you share your screen?
Sure.
Jordi at the end alluded to the rapid diagnostic testing, but that will be the fourth topic in 15 minutes. Haifa, are you there? Yeah, okay. Now we see introduction. Okay.
Yes, sorry. So one of the greatest concerns that has emerged in the recent decades is steady escalation in the global resistance against antibiotic among certain strain of bacteria, accompanied by elevating mortality. Around 70,000 people currently die annually because of MDR bacteria, and it will increase to 10 million annually by the year of 2050. So in 2017, World Health Organization published 12 families of bacteria they consider to pose the great threat to the human. It categorized in 3 categories: critical, high and medium priority, based upon the urgency for need for effective intervention to be developed and put into clinical practice. 6 multi-drug resistant pathogen listed as critical priority are Enterococcus faecium, Staphylococcus aureus, Klebsiella pneumonia, Acinetobacter baumannii, Pseudomonas aeruginosa, and Enterobacters. Recent example of such organism transition from benign contaminant to a highly lethal pathogen is Acinetobacter baumannii, with increased resistance to carbapenem and 40-60% in some countries, up to 80%. So mortality rates with gram-negative MDR resistant bacteria as high as 80 to 85%. So we'll talk about strategies that reduce antibiotic resistance in ICU, so preventing drug resistance from developing, and what strategies that prevent spread of antibiotic resistant organism. So strategies already discussed by previous speaker, that antibiotic stewardship and antibiotic de-escalation, then the rapid diagnostic testing, use of biomarker like procalcitonin for to decide about cessation of antibiotic, new antibiotics recently available, and emerging supplementary antimicrobial therapy. Preventing spread of antibiotic resistant organism like include environmental cleaning, decolonization and source control, proper hand hygiene, isolation, and education. So why MDR bacteria increase in the past decades? Because bacteria innately change over time in response to their environment, whether the environment is within human, animal, or plants, use a lot of antibiotic in the veterinary and agriculture, increase the changes in bacteria, and this lead to antibiotic resistance. The other main reason is non-judicious use of broad-spectrum antibiotic in ICU patient, and this is like explained by that most of ICU patient all has a life-threatening infection, either whether develop on admission or while they are in the ICU. So other risk factor that increase risk of MDR bacteria in the ICU is the clinical feature related to the patient, like patient has a high severity index and need intervention, ICU acquired type of infection, patient already on antibiotic or antifungal, colonization, which may lead to infection, local epidemiology, and poor practice in the ICU. Antimicrobial stewardship already has been presented by Prof. Jandueli. So it's proven that it decreases antibiotic cost, use and cost, decrease shorter time, reduce incidence of antibiotic-resistant infection without worsening outcome. It proven that it decreased consumption by 19.1% and typically in ICU by 39.5%. The use of broad-spectrum antibiotic also declined the use of antibiotic by 18.5% for carbapenem, 14.7% for glycopeptide, and overall cost reduced by 33.9%. So a lot of study that already has been discussed and shown that antimicrobial stewardship and antimicrobial de-escalation decrease antimicrobial resistance without changing in the outcome. Availability of rapid diagnostic testing can minimize or decrease the risk of MDR bacteria, because we know that the major contributor to the overuse of broad-spectrum antibiotic is the time delay between admission of the ICU patient until the culture result return, and this is because of depend on the conventional method with microbial growth. So this may take like 36 to 70 hours until it's back with the susceptibility. This is advantage that we have susceptibility, but take time. So there is a need for a new diagnostic tool, which is like it's available. The turnaround time between 1 to 8 hours. It's used like detection of the DNA or protein of the bacteria, but again, lack of standardization, expensive, not available all the time. We need really expert microbiologists, and we need people that know what are the limitations of each diagnostic test before depends on using them. So once it's proven that is decreased antibiotics and proof will be that reduced development and spread of antibiotic resistance, we need really more rapid diagnostic testing. Procalcitonin has been used to guide and stop antibiotic therapy in ICU patient. It reduced mortality using that with de-escalation of antibiotic, reduced mortality and length of stay, and has been proven in multiple clinical trials and meta-analysis. And as you see, like it decreased the duration and time and consumption of antibiotics in the ICU. And if you see that trials in emergency and intensive care unit that in favor of using procalcitonin as a guidance for cessation of antibiotic. So all those evidence proving that it helped in antibiotic de-escalation and decrease cost and decrease risk of infection, but it's not already proven that it reduced the incidence of MDR bacteria. New antibiotics in the is available now. Some of them already approved and use, others in phase 3 trial or use of the old antibiotics, but optimizing pharmacokinetics and pharmacodynamics according to like a lot of factors play in ICU, like increased volume of distribution with renal impairment. So this all like we need to achieve according to the pharmacokinetics and pharmacodynamics with old or current antibiotics. Supplementary therapies has been available and we can use in combination with antibiotic like bacteroids, antimicrobial peptides, photodynamic light therapy, and silver nanoparticles. It has been used for to minimize risk of or need for antibiotic, decrease wound healing in dental, skin, and soft tissue infections, but unfortunately, only a few data supporting its effectiveness in humans. Moving now to the strategies that prevent spread of antibiotic resistance, which is environmental cleaning, decolonization and source control, proper hand hygiene, isolation, and education. So environmental cleaning, decolonization and source control measures are used to decrease spread of infection. And this should be stress for not only patients, caregiver, nurses, everybody in the hospital. We should pay attention to the all measures or infection control measures to prevent transmission of infection, including personal protective equipment like mask, shield, gloves, gown, and should be used appropriately. Use of antibiotic stewardship compared with the standard of care, plus the 3 measures to decrease spread of infection, which is source control, decolonization. As you see, that it's proven that it's effective compared to the standard of care when it's used all together. So CDC has already published guidelines on how to decontaminate the environment, patients, and healthcare and personnel, and mention this approach. Most of them are really in practice, but we just some area that really need to be cleaned consistently and thoroughly, and we missed most of the time, like cleaning bedpan, toilet area, handhold, doorknobs, light switches, other remote area, which is like a good area for bacteria like Acinetobacter baumannii can be found in the computers, computer keyboards, medical chart, door handles, elevator button, water taps. So all those should be cleaned appropriately to avoid transmission of resistant organism. The other measures that obviously it's help in prevent or transmission of MDR organism are hand washing, but unfortunately it's only 40 to 60% compliance to the hand washing, and this is maybe because of time. Like this one study, German study, showed that nurses usually the recommendation 30 to 40 seconds, but the hand washing by nurses 6.8 seconds, which is 23.3 seconds less than the WHO guideline, and this is because of time constraint. So if the nurse need to wash their hand 200 to 2071 time, which is may need 58 to 70 minutes. This means that in the 12-hour shift, this is really time consuming. So without flexibility and the additional, like putting additional staff and help hand washing will not be appropriately done. Isolation is another method that decreased spread of infection. So either isolate patient with MDR organism or empiric isolation. And the problem that isolation for those patients until identification of organism may take days. So already bacteria has been spread. So that's why the rapid diagnostic testing is mandatory. The other important thing that, or suggestion that not isolating patient only, but isolating their nurses along with hand hygiene and masking and gloving may help reduce the transmission of infection. So the effectiveness of any measure designed to reduce antimicrobial resistance and the spread of resistant organism rely on how well and how consistently they are implemented, and rely on all affected parties being educated in the process, like including healthcare worker, patients, visitors. Everybody in the hospital should be educated about sticking to the infection control measures. So MDR organism is a global health crisis, and strategies are available. So what we need now is to strict adherence to those practices that have already been documented to be effective, combined with the concerted effort to further develop and test those approaches whose effectiveness remain unknown till now. Thank you very much, and happy to have questions at the end.
Thank you very, very much. That's a lot of material that you presented there. You covered a wide spectrum of aspects and strategies, and this was very interesting. Indeed, we will go to the fourth presentation before taking all the questions. We are now more than 250 participants, and it's my pleasure then to invite Professor Ryan Maves from Infectious Disease at Wake Forest to discuss the rapid molecular tests to improve antimicrobial use. Ryan?
Well, thank you very much, sir. And just I have to say what a pleasure it is to be part of such a distinguished panel. I'm not sure how I got invited to this. I'm sure there was some error in the email system. So my name is Ryan Maves.
Not at all.
I'm a critical care physician and an infectious disease physician at Wake Forest University in Winston-Salem in North Carolina in the United States. So Dr. Algethamy, these are my disclaimers. I have some research support to my institutions and some advisory panel memberships. None of this has anything to do with what we'll be talking about, though. So the scope of the problem, and of course, just to briefly summarize what our colleagues have said earlier, is that we know in critically ill patients that delayed active therapy, meaning an antibiotic that treats the infection you actually have, increases mortality, at least in septic shock and to some extent in hemodynamically stable sepsis as well. And we see this from the work of Dr. Anand Kumar and many other distinguished colleagues from CHEST in 2009, where delayed inappropriate empiric therapy, say vancomycin for gram-negative infection, those patients die more. We also see that increased antimicrobial use increases the risk of resistance. So, for example, here, carbapenem exposure is strongly correlated to the later development of carbapenem-resistant infections. We also know that we have difficulty distinguishing at the bedside at the time of presentation between bacterial, fungal, and viral causes of sepsis, or in fact, non-infectious causes of systemic inflammation that resemble sepsis. This is by Dr. Chappell and Dr. Klompus and Ochoa and colleagues from Critical Care Medicine in 2021. 35% of patients with suspected bacterial sepsis who receive broad-spectrum antibiotics in emergency departments do not have bacterial infections. And then lastly, we have the challenges, of delays intrinsic to culture-based assays. It takes 48 to 72 hours to get actionable results from culture-based assays on a good day. And the technology we use for cultures is fundamentally the same as that developed by Ms. Fanny Hesse in 1881 using agar, essentially grinding up seaweed and growing bacteria on it. This is the gold standard on which we rely, but we are in a situation where we have to make decisions based on 72 hours in the future. So what can we do about this? So how can we make decisions faster and better? These technologies are in rapid development, but the optimal solution we're looking for is something that is rapid, that is actionable, meaning it gives us data that affects clinical decisions, that is both sensitive and specific. On some level, it needs to be capable of detecting antimicrobial resistance. If that weren't an issue, we could just put everyone on Vanc and Miro and let her rip, right? And then lastly, there are pros and cons to different types of assays, PCR-based assays versus antigens-based assays versus various biomarkers. I'm not going to get into procalcitonin and related ones. Dr. Algethamy discussed that very, very clearly just a moment ago. There are a number of commercial assays and investigational assays right now. And the ones I've highlighted here, upper and lower respiratory tract infections, bloodstream, and then rapid detection of resistant genes, those are the ones we're going to focus on. But it's useful for folks to know that there are reasonably effective, for example, GI panels now that can rapidly identify, say, Campylobacter from a diarrhea specimen or neurologic specimens. We've actually started using a very helpful bone and joint panel here on our infectious disease consult service at Wake. So we'll start by looking at respiratory infections. So there are multiple commercial assays that are currently available. FilmArray is a common one. Univero is another one that is relatively widely used depending on where you work. So these provide semi-quantitative detection of multiple pathogens, as well as common determinants of beta-lactam resistance. And I have to underline that, it's beta-lactam resistance. So far, we don't have many assays that reliably rapidly detect non-beta-lactam resistance. And this is for a number of reasons, one of which is that the genetics of, say, quinolone resistance are much more complicated than, say, methicillin resistance in Staphylococcus aureus. There are a number of these assays that detect viruses as well. Older LRTI panels or older lower respiratory tract infection panels may not detect SARS-CoV-2. That has started to change in the last few months, but a lot of these panels, when they say coronavirus, they're referring to the previously endemic coronaviruses that were commonly associated with upper respiratory tract infections. But most of these assays, and here on the right, this is an example, just as an example from the BioFire pneumonia panel. They'll detect MEC-A and MEC-C, which are the most common determinants of methicillin resistance in Staph aureus. They'll detect usually CTXM, which is the most common ESBL in North America. Obviously, your geography is going to play a big role here in which is most useful. And then carbapenemases, OXA, NDM, VIM, KPC, and IMP. So what is the impact of this on you? So this was the Inhale WP1 study. This is a multi-center study that looked at 625 specimens from patients with suspected hospital-acquired or ventilator-associated pneumonia done in the United Kingdom. And what they found is by routine microbiology, they detected a pathogen 44.2% of the time. But with these two different commercial assays, the numbers were much better. Now, FilmArray did a little bit better in this assay, but nonetheless, they were both solid improvements in being able to identify a pathogen and hopefully adjust and improve therapy more quickly. If you look harder at what were the culture negative detections, 73 culture negative detections where the PCR assay identified a pathogen, but culture did not. About 8.2%, depending on the patient studied, just for whatever reason, culture failed. However, a large number of them were either reported out as, quote, normal oral flora. And there is some discussion about whether some of these oral streptococci play more of a role in pneumonia than we appreciate. And then another half of them were largely the result of empiric antibiotic use before the assay was obtained, before cultures were obtained. This is a very difficult to prevent problem. And these PCR assays may help us get around that. Now, if you look at see what do clinicians actually do with the results, again, this was a separate study, but looked at whether or not patients had appropriate de-escalation or discontinuation of antibiotics in the study, and about half of them did. However, unfortunately, about a sixth of them continued on unnecessary broad spectrum therapy. And this is going to be just like especially like Dr. Algethamy mentioned earlier, this is where the integration of stewardship becomes important. We need to have not just better tests, but better mechanisms to get clinicians at the bedside to modify our prescribing practices in response to good test results. Okay, let's take a look at bloodstream infections. So bloodstream infections with conventional automated blood culture systems, they are continuously monitored, but they're fundamentally binary. A blood culture is positive or negative. It is difficult to get, say, semi-quantitative results. There are techniques you can use for that, but they are less useful. There is a strong impact of prior antimicrobial use, unfortunately. And as I mentioned earlier, you are at best going to be waiting 48 and generally up to 72 hours before you have identification of a pathogen and susceptibility results available to help you modify your treatments. So when we look at rapid diagnostic assays for bloodstream infections, there are methods that use rapid gene detection for positive blood cultures. There are rapid species identification with MALDI-TOF. There are now emerging assays that use whole blood multiplex PCR off of a whole blood specimen obtained at the time of patient presentation. Really, and then the future, next generation sequencing based on cell-free DNA, 16S ribosomal RNA, and related assays. So looking just at a couple of some of these rapid tests, there are a number of assays out there. These rapid tests require you to have a blood culture bottle basically pop positive. And the reason is that they lack an amplification step. So you need a certain threshold amount of bacteria in the specimen to be able to run the test. And generally what this is a positive blood culture with a positive gram stain. If you have that, it is probably enough genetic material. They do detect common beta-lactam resistance markers. With staphylococci, this is very good. If you have Staph aureus and you don't detect MEK-A off that assay, it's not MRSA. The positive predictive value for things like ESBLs and carbapenemase producing Enterobacteriaceae is very high, but the negative predictive value is more limited. There are ESBLs and carbapenemases that slip through detection. And this is, again, because gram-negative resistance is very genetically complex. Most of these assays, the only ESBL gene they detect is CTXM. There are others, and again, where you practice in the world plays a big role. And with Pseudomonas, there's a lot of non-enzymatic resistance that will not be detected on these assays. Now, this is MALDI-TOF, and I include this picture because it amuses me, but this was the day my old hospital got our MALDI-TOF machine, and this was me getting to know it on its first day. So this is matrix-assisted laser desorption ionization time of flight. This is basically mass spectrometry performed on a positive culture. Now, you have to have a culture growing on a plate, but it does save you a day because it gives you identification of species at least within an hour. It is interesting that there are some species that we can't differentiate by MALDI-TOF. E. coli and Shigella are the same species, essentially, for example. The differences between them are relatively minor. MALDI-TOF can't tell them apart. This is an interesting concept, though. We can't use MALDI to detect drug resistance yet. But there are studies that look at, for example, putting beta-lactam antibiotics, incubating them relatively briefly within culture specimens, centrifuging them down, and then looking to see if you can detect beta-lactamases by detecting hydrolysis product of beta-lactams in the MALDI-TOF. This is just investigational, but it does show that there may be a path forward for using MALDI to identify drug resistance. Now, the holy grail, if you will, is potentially whole blood PCR, where you take a blood specimen and then you just do a multiplex PCR for the most common pathogens, generally looking about 90 distinct pathogens. Of course, you're not going to detect stuff that isn't on the panel, Achromobacter, for example, but it is fast. It is less sensitive, about 29% sensitive compared to a blood culture standard. But if someone has received antibiotics, it is more likely to be positive in that setting. This may be something that will improve with time, but I propose that probably the actual holy grail, if you will, is going to be next generation sequencing. This is a measurement of circulating non-human cell-free DNA from patient plasma. This is potentially very rapid. It is not pathogen specific. You don't need to have the organism in the panel. What you do need is a bunch of reference and control specimens from healthy adults to account for the microbial DNA that you normally find in human plasma, like Cutibacterium or Staph epidermidis, be able to screen out the background non-human DNA noise to identify things. And this graph here just shows an example of a patient with Enterobacter cloacae bacteremia who is compared against background samples with patients with Propionibacterium and the like. There is some observational data backing up this study. This was a study done in Germany, 15 patients with septic shock, mainly of abdominal source. They are compared to 20 control patients who underwent elective surgery. 33% blood culture positivity baseline in septic patients, 72% of patients, excuse me, compared with the 72% detection rate for next generation sequencing, much more rapidly than cultures came back. And 53% of these findings would have led to changes in therapy. There is going to be a forthcoming prospective multi-center study called Next Genesis that will start to validate this approach more formally. So where does this leave us? Culture is not dead yet. It still remains our gold standard, but we need to have a way to be able to identify patients both with the actual pathogens affecting them so that we can target our therapy, and to find some way to at least identify the great majority of antibiotic resistance, or at least beta-lactam resistance quickly. We still need phenotypic testing in culture plates. We still need culture to identify novel mechanisms of resistance. There is still some difficulty distinguishing between important pathogens like E. coli and Shigella. All of this, in order to work, needs close coordination with your stewardship programs. But if we make this work, rapid identification of pathogens can improve antimicrobial selection up front, hopefully reduce toxicity, and all of this together has a goal of improving patient outcomes. This is me. Thank you again for the opportunity to speak to you today. I really am most grateful for the opportunity.
Thank you very, very much indeed, Ryan. That was very interesting, and it also raises a number of questions. Our time is quite limited for our questions, but we will try to have a few ones. And we received a number of questions from our 250 plus participants. And perhaps the first one, well, perhaps it could go to Jordi Rello. A participant is raising a specific point. He says, or she says, that if you have a patient who was treated successfully, let's say for a urinary tract infection, and it was successful, but the patient comes back to the hospital, let's say 10 days later, can we start with the same symptomatology? Could we start with the same antibiotic, or is it already a situation where we would like to treat with another antibiotic to change the pressure? Jordi, are you there? No. Jordi? Jordi Rello? No. Oh. Jordi, are you there? No. I see him, but nothing moves. Jordi? Jordi Rello? No. Okay. Jan de Waele, the pharmacokinetics and pharmacodynamics, that costs some money. It asks quite a bit of work for the lab. Should we do it quite routinely in many septic patients, or should we limit it to some indications, please?
That's the million-dollar question, Jean-Louis.
Yes. A question for the expert.
Well, as you know, of course, there is no compelling evidence at this stage that what we advocate, the optimized approach with a prolonged infusion and high dose and TDM, actually leads to better, improved outcomes. There is a randomized controlled trial that was just finished, and hopefully we'll get results soon, looking at prolonged infusion and see what the value is of that. There is a systematic review suggesting that indeed outcomes are better when giving drugs in continuous infusion. So that may be an option, yes. I think TDM for beta-lactam antibiotics is promising, fits the whole concept. But at this stage, we've seen a number of studies so far that we're not able to prove convincingly that we should be doing it. I think we should investigate it at this point and get ready for it, maybe, yes. But TDM at this stage, I think it's research mainly or specifically for difficult to treat pathogens or situations that are very complex with a patient on ECMO and RRT, et cetera, et cetera, et cetera. Yes, you can make sure you can use it there to make sure that you actually have adequate concentrations, what we think are adequate concentrations.
Yeah. Ryan, would you agree with that?
Oh, absolutely. I am hopeful that extended infusions, either continuous infusions or these prolonged 3 to 4 hour infusion times, will be effective in reducing mortality. Jason Roberts in Australia has done a lot of this work, and very, very compelling. But it remains to be proven, as he said. And I'm share that interest in finding out whether or not this is useful. TDM, I'm a little more skeptical of. I'd rather optimize dosing in a broad patient population before seeing how TDM works, other than the obvious examples like certain antifungals and vancomycin and aminoglycosides.
Right. Haifa, someone asks, should we have environment screenings in our ICUs? It's also quite a bit of work. Is it worth it? Are you there?
Yeah. Yes. Maybe for high-risk patient, but screening, I think it's waste of time and resources. So whenever there is a sign or high-risk patient, then probably will do. Otherwise, it shouldn't be routine practice.
All right. Jordi, are you back now? Jordi Rello? Jordi Rello? No? Okay. Ryan,
yes.
Someone
yes.
asked, who said yes? Jordi, you said yes?
Jordi Rello.
Ah,
yeah.
Okay. Did you hear the previous question? Someone asked if did you ask about did you hear about the urinary tract infection that was treated successfully? Now the patient comes back to the hospital 10 days later with the same symptomatology. Can I give the same antibiotic, or should I change to have a different type of antibiotic pressure on microorganisms?
It's a very good question, because it would be expected that giving the same therapy, the patient will recover. But what it is more common when patients present recurrence is that they have a different phenotype with the same genotype. In other words, the same organism has acquired resistance to the prior antibiotic exposure. And like normal management, it is recommended. Hello?
We cannot hear you, Jordi.
Sorry.
Can you repeat your last words?
A different antibiotic is the answer. A different antibiotic it is needed to avoid the initial prescription session.
Mm-hmm. Yeah. Jan, would you agree with him? You did not hear everything, but what would be your strategy? Jan de Waele, we cannot hear you. You can all unmute yourself so that Jan de Waele. No, we cannot hear you, Jan. You are muted. You are muted, Jan. You can unmute yourself. No. Ryan, what do you think as Jan is getting ready?
Oh gosh, I mean, I think if you know that the recurrent isolate is the same as the previous one, and you have the initial index drug remains susceptible, I think you can retreat it. The question is, what do you do at the time of presentation before you have that culture result back? I think it is certainly very wise to use a different drug. Generally, when people have recurrences due to the same pathogen, at least in the urinary tract, more often than not, it's a source control challenge. There is an infected stone, there is an abscess. In kidney transplantation, there's obviously there's occasionally some microvascular focus that requires more prolonged thing. But yeah, what do you do when that patient first shows up? Certainly switching therapy is appropriate while you try to sort it out. But that gets us back to that 48 to 72 hour delay in culture results.
Yeah, right. Yeah.
We agree.
You agree, Anne? Yeah. Haifa, when we do all these hygienic measures, these isolation procedures, it's quite expensive too, and it's a lot of work too, and the personnel may not like it too much when you have to take this equipment on before entering the room. So do you think sometimes we are doing too much? Haifa, are you there?
Well, yes, if we know that drug resistant is increasing, and this is associated with increased mortality, and until we have more or new easy strategy or faster strategy, probably we have to do this, because we want to protect our patient, ourselves, and visitors. So it's worth to do all this effort. I think just like be flexible and increasing more people, more staff, especially for nursing staff and respiratory therapists when they handle a patient with MDR bacteria.
Okay. So you would be quite strict about all this. Ryan, with the molecular tests, isn't there a risk of identification of too many organisms? You insisted on sometimes poor susceptibility, but perhaps sometimes it's excessive sensitivity.
No, that is exactly the danger. And actually in this week's, I want to say it's JAMA Neurology, there's a very nice article on the use of rapid molecular testing in neurologic infections. And they, the authors of this paper, point that out, that there is a point where you're detecting things that are of no particular consequence, and this could lead to overtreatment. Some of these assays have semi-quantitative components to it. So, for example, a number of the lower respiratory tract panels give you a quantification of 10 to the 5th, 10 to the 6th colony-forming units detected, and I think that helps screen out a little bit of that. That if you find something at a very low level, but the purely qualitative assays that are just binary, yes or no, I do agree, and that is one of the dangers. We saw that with Clostridium difficile or Clostridioides difficile when C. diff PCRs first came into widespread use. We found a ton of C. diff in people who were minimally symptomatic and probably had diarrhea because of tube feeds or whatever. So that is absolutely a danger, and that's a very thoughtful observation.
Okay. Jan de Waele, a very hot topic today is SDD, selective decontamination of the digestive tract, with the latest study from Australia, the meta-analysis, etc. Is there a substantial risk of antibiotic resistance if we now start to use it everywhere in the world?
That is, again, a good question, Jean-Louis. And indeed, the recent trials from Australia, New Zealand, previous trials from the Netherlands showed that in these areas of low levels of antimicrobial resistance, it seems to work fine and improve outcomes. But the question remains whether indeed in areas with medium or higher levels of antimicrobial resistance, this still holds true. Of course, in SDD, again, maybe for the audience, you combine oral antimicrobials as well as a short course of intravenous cephalosporin antibiotics, which of course increase the antibiotic exposure, and there's an inherent risk of antimicrobial resistance developing. Now, it should be said that in those countries, in those studies, and these are studies that included thousands of patients, so this is really big groups, there was no real trace of antimicrobial resistance developing in these countries. And this is probably one of the reasons why a lot of people in areas with higher levels of antimicrobial resistance are still reluctant to implement this. So yes, it seems to work. And if you have a low level of antimicrobial resistance, it doesn't seem to be increased, but the jury is still out. What happens if you would do this in South Europe, the south of Europe, for instance, or other areas with higher levels of resistance compared to the Netherlands and Australia, where it has been studied?
Yeah. Jordi, of course, you're also an expert on this. Can you summarize your thoughts so that we could hopefully hear them? Do you agree?
I fully agree with the opinion expressed by Jan.
Okay, thank you. And Ryan, a view from the US. In the US, people have been more skeptical about SDD in general.
I think that's fair, and I share that skepticism, to be honest with you, although I fully acknowledge the earlier trials from the Netherlands that show a lot of support. I think in the North American context, it's a little tricky because I look at antimicrobial resistance in the Netherlands and Belgium with unabashed envy, and so a lot of strategies that are effective in such a low resistance environment, I am concerned would be less effective here, and particularly when you get to areas like India and Southeast Asia. That being said, that the meta-analysis it was in that was published in JAMA yesterday was very interesting, and I've tried to keep an open mind about it, I suppose is the answer. And in those studies, they are not finding higher rates of resistance. I don't know how much it impacts mortality, but they're not seeing resistance changes and are looking for it very hard.
Yeah. Now, when you say the Netherlands and Belgium, you must know that we have more resistance problems in Belgium. And our Dutch colleagues say that when there is a Belgian patient crossing the border, the patient is isolated right away because they are concerned about resistant organisms. It's not as bad as in the south of Europe, of course, but it's not as good as in the Netherlands. Well, I would have loved to continue the discussion, but I'm afraid our time is really past now. And so I will thank you all for your contribution. I think we had a good time together, and we do thank you very, very much. Take care. Bye-bye.